Hello, my name is Craig Lomita, and I'll be talking about common disorders of the elbow. The first we'll be discussing is cubital tunnel syndrome. This is a compression of the ulnar nerve at the elbow. The incidence is 25 per 100,000 persons per year. It's more common in men than women. It's the second most common compressive neuropathy after carpal tunnel syndrome. Clinical signs include paresthesia of the ring and small fingers in the ulnar nerve distribution, intrinsic weakness, and wasting. Wartenberg sign, inability to adduct the small finger due to paralysis of the third volar interosseous, with abduction caused by the extensor digiti minimi. Frohman sign and Jean sign, IP joint flexion and MCP joint hyperextension during key pinch, with the flexor pollicis longus compensating for loss of MCP joint flexion due to paralysis of the adductor pollicis. Physical exam also consists of a Posentinel sign over the medial elbow, as well as reproduction of the patient's symptoms with prolonged elbow flexion. EMG is also helpful in confirming diagnosis. Anatomy and points of compression. The most common is the cubital tunnel at the medial elbow posterior to the medial epicondyle. The roof of the tunnel is Osborne's ligament, which is an aponeurosis of the flexor carpi ulnaris running from the olecranon to the medial epicondyle. The floor is the medial collateral ligament of the elbow. Arcade of Struthers, an aponeurotic band that can run from the medial head of the triceps to the medial intermuscular septum. It lies approximately 8 centimeters proximal to the medial epicondyle. The medial intermuscular septum itself, osteophytes from the medial epicondyle, and Osborne's ligament at the cubital tunnel. The anconeus epitrochlearis, an anomalous muscle which arises from the medial border of the olecranon and the adjacent triceps and inserts into the medial epicondyle, seen in 10% of patients. The arcuate ligament, the aponeurosis of the flexor carpi ulnaris connecting the ulnar and humeral heads, as well as the deep flexor pronator aponeurosis distal to the cubital tunnel. The Dellon classification is the most commonly used classification. It looks at whether the patient's paresthesia is intermittent or persistent, and whether their motor involvement is subjective, measurable, or whether they have a palsy. The type 2 is the most common. Treatment can consist of activity modification, having the patient avoid prolonged elbow flexion and nocturnal elbow extension splinting. Surgical treatment consists of ulnar nerve decompression with possible transposition if the decompressed nerve is unstable with elbow flexion. This can be done in a variety of ways. Epicondylitis can be lateral or medial. Lateral epicondylitis or tennis elbow is an overuse injury involving eccentric overload at the origin of the common extensor tendon, leading to tendinosis. It's the most common cause of elbow pain in adults and is common in racket sports. You see tendinosis or chronic degeneration of the tendon, with the ECRB most often involved. There's microtearing and angiofibroblastic hyperplasia, seen histologically with increased fibroblasts, vascular hyperplasia, and disorganized and immature collagen. Symptoms and physical exam findings consist of tenderness to palpation of the lateral epicondyle, pain with resisted wrist extension, pain with gripping activities, decreased grip strength, and pain with resisted extension of the long finger. Imaging diagnosis is primarily clinical. Walton in 2011 showed that MRI was a reliable tool in determining radiological severity, but severity of MRI signal changes did not correlate positively with symptoms. Treatment, non-operative treatment consists of activity modification, ICE, NSAIDs, and physical therapy, sport-specific modification of technique and equipment, counterforce bracing, steroid injections, and stretching of the extensors. And you can see up to a 95% success rate with non-operative treatment. Surgery is typically done if non-operative treatment fails. This can be open versus arthroscopic with debridement of the lateral epicondyle and repair of the healthy tendon. Medial epicondylitis is an overuse injury of the flexor pronator mass. Again, it is a tendinosis and it is 5 times less common than lateral epicondylitis. On exam, patients will be tender over the medial epicondyle and have pain with resisted forearm pronation and wrist flexion. Treatment treatment is similar to the treatment for lateral epicondylitis. Non-operative treatment is the first line, and operative treatment is reserved for people who fail non-operative treatment and tends to be less successful than with lateral epicondylitis. Radial head fractures are the most common elbow fractures seen in adults. The mechanism of injury is a fall on an outstretched hand with the forearm in a pronated position and axial load created across the elbow. The Mason classification is the most commonly used classification. Type 1 shows a minimally displaced fracture with no mechanical block. Type 2, a displaced fracture with a possible mechanical block. Type 3 is a comminuted and displaced fracture. And type 4 is an elbow radial head fracture with elbow dislocation. Imaging consists of X-rays, and CT is very helpful to assess comminution, displacement, and to guide surgical management. Non-operative treatments can be performed for fractures with minimal displacement and no mechanical block. You need to avoid prolonged immobilization to prevent stiffness. Displaced comminuted fractures, or those with a mechanical block, are typically treated with surgery. Open reduction and internal fixation is an option. The outcomes are better with less than 3 fragments. You can do a fragment excision if the fragment is less than 25% of the articular surface. You can resect the radial head. This is typically reserved for low-demand sedentary patients. This can lead to instability, and you need to avoid it in situations with fracture dislocations or concomitant coronoid fractures, interosseous ligament injuries, or medial collateral ligament injuries. Arthroplasty can be performed for comminuted fractures, or those non-amenable to open reduction and internal fixation, or when there are associated instability injuries. You need to avoid overstuffing or oversizing the implant and avoid silicone implants, as this can lead to fracture of the implant or synovitis. Instability of the elbow. When discussing instability, it's helpful to think of primary and secondary stabilizers. When a primary stabilizer is injured, the secondary stabilizer becomes a primary stabilizer. Valgus instability, we need to discuss the medial collateral ligament complex. The anterior bundle of the complex runs from the anteroinferior aspect of the medial epicondyle to the sublime tubercle on the anteromedial coronoid process, and this is the primary stabilizer of valgus stress. There's also the posterior bundle running from the medial epicondyle to the medial olecranon, and the transverse ligament running from the sublime tubercle to the medial olecranon. The radial head is a secondary stabilizer in valgus instability. It is of importance in combined injuries. The flexor pronator mass is also a secondary stabilizer. So you get valgus instability with rupture of the medial collateral ligament complex. This can be an acute rupture, or it can be an overuse injury seen in throwing athletes, or it could be iatrogenic. In the history, the patient may report a pop during the throwing activity with pain, loss of control, or loss of velocity during throwing. On physical exam, the patients may be tender to palpation of the medial collateral ligament origin. You can perform a valgus stress test with the elbow held at 20 degrees of extension, externally rotating the humerus, and applying valgus stress to recreate the patient's symptoms. The milking maneuver is done by pulling on the patient's thumb with the forearm supinated and the elbow flexed, causing apprehension, instability, and pain. The moving valgus stress test is performed by having the examiner apply and maintain a constant moderate valgus torque to the fully flexed elbow and then quickly extending the elbow. The test is positive if the medial elbow pain is reproduced at the medial collateral ligament origin and is typically at its maximum between 120 degrees and 70 degrees. O'Driscoll in 2005 showed this at 100% sensitivity and 75% specificity. On X-rays, you can see opening of the medial joint line and posteromedial osteophytes in more chronic conditions. On MRI, specifically the T2 weighted coronal sequences, you'll see tearing or thickening of the ligament. MR arthrogram may be helpful, as well as dynamic ultrasound. Treatment, you can try non-operative treatment in non-throwing athletes or throwing athletes with partial tears. You can do therapy for flexor pronator strengthening. Ford in 2016 looked at 43 elbows and 43 pitchers and found that distal ruptures are more likely to fail non-operative management. Operative treatment is often done for throwing athletes or non-throwers who fail non-operative treatment and typically consists of ligament reconstruction with a variety of ways to fix the graft. You can do bone tunnels or a docking technique or interference screws. Posterolateral rotatory instability is disruption or incompetence of the lateral collateral ligament complex. It's also the first stage of a frank elbow dislocation. It typically occurs after acute valgus stress, fall onto an outstretched arm with axial loading, valgus stress, forearm supination, and elbow extension. It could also be iatrogenic or chronic attenuation in a cubitus varus deformity. In discussing the anatomy, the lateral collateral ligament complex consists of the lateral ulnar collateral ligament. This runs from the inferior aspect of the lateral epicondyle to the supinator crest of the proximal ulna and is the primary stabilizer of varus stress and posterolateral stability. The radial collateral ligament runs from the lateral epicondyle to the annular ligaments. The annular ligament encircles the radial head, and the accessory collateral ligament runs from the annular ligament to the supinator crest. The common extensor tendon is a secondary stabilizer to varus stress. Symptoms consist of lateral elbow pain and clicking with elbow extension. On physical exam, patients can be tender of the lateral collateral ligament and have a positive lateral pivot shift test done with the patient supine and the forearm supinated, valgus stress applied, and elbow flexed. The chair push-up test consists of lateral elbow pain or apprehension when using arms to push up from a seated position with the shoulders abducted, forearms supinated. The tabletop relocation test has the patient pushing up from a table and experiencing apprehension and pain at the lateral aspect of the elbow with pressure on the radial head resolving the apprehension. The floor push-up test is similar to the chair push-up test. Imaging consists of radiographs and MRI, and specifically on the T2 coronal views, you'll often see thickening or rupture of the ligament. Acute treatment would consist of short-term splinting with the forearm in pronation if the medial collateral ligament is intact, with surgical repair if concentric reduction cannot be maintained. Chronic injuries are treated by reconstruction. You're reconstructing the lateral ulnar collateral ligament using autograft. You're creating a sling to support the radial head, and again, this can be done with bone tunnels or interference screws. Terrible triad injuries are fracture dislocations of the elbow. They involve disruption of multiple bony and soft tissue stabilizers of the elbow. The triad is a radial head fracture, coronoid fracture, and lateral ulnar collateral ligament rupture, though you can also have other injuries such as a medial collateral ligament rupture. Again, the primary stabilizers of the elbow are the bony articulation of the ulnar-humeral joint, the anterior bundle of the medial collateral ligament, and the lateral ulnar collateral ligament. Secondary stabilizers are the radiohumeral articulation, the common extensor tendon, the flexor pronator mass, and the joint capsule. You can think of elbow stability and as a fortress, with the primary stabilizers being the outer wall. And if one of those are breached, then the secondary stabilizer takes over. There are also dynamic stabilizers of the elbow. These are muscles that cross the elbow joint, the triceps, the biceps, the brachialis, and contracture of these dynamic stabilizers allows for compression across the joint and stability. Imaging consists of radiographs, and CT is very helpful to assess for the coronoid fracture and the radial head fracture. These typically are treated with surgery. Non-operative treatment tends to be associated with with instability and stiffness. You really need to demonstrate a stable arc of motion if you're treating these non-operatively, and confirm concentric reduction on radiographs. Operative treatment typically starts with a lateral exposure, repair of the coronoid fragment from the lateral side if possible. If not, it can be addressed from a medial exposure. Once the coronoid is dealt with, radial head replacement versus ORIF, and finally repair versus reconstruction of the lateral ulnar collateral ligaments. If the elbow is still unstable, you can perform a repair or reconstruction of the medial collateral ligament, placement of an internal joint stabilizer or internal hinged fixator, or placement of an external fixation. Cubitus varus deformity, also known as gunstock deformity. In normal anatomy, the distal humerus shows a valgus angulation of 5 to 15 degrees, which is greater in women. This is referred to as the carrying angle. And loss of this normal valgus angulation is typically seen following a malunited supracondylar distal humerus fracture. It's typically a cosmetic deformity. It can be treated with an osteotomy of the distal humerus. It's important to medialize the distal fragment to prevent a bony prominence laterally. Elbow arthritis can be osteoarthritis, post-traumatic arthritis, or inflammatory arthritis. Treatment of osteoarthritis and post-traumatic arthritis consists of anti-inflammatories, activity modification, heat, steroid injections, and with rheumatoid arthritis, in addition to that, anti-rheumatoid medications. Elbow arthroplasty can be performed in patients who fail non-operative treatment. The ideal patient is someone who's over 65 years of age and sedentary who has failed non-operative treatment. There's a lifetime restriction of 5 pounds of lifting or 2 pounds for repetitive lifting or repetitive tasks. Arthroplasty in the elbow is not as durable as in the hip or knee. Bone cement works best under compression, and elbow arthroplasty implants are placed under tension or traction. Elbow arthroplasty, the risks include loosening, infection, and periprosthetic fracture. Infection can present as chronic pain, warmth or erythema, loss of motion, or loosening of the implant. Just like with lower extremity total joints, you can divide infections into acute, subacute, or chronic. Imaging on x-rays, you can see early loosening of the implant. You can see an elevated ESR and CRP. These are not specific. The white count is often not elevated. Oftentimes you need to do an aspiration of the joint, as well as possibly obtain intraoperative cultures and histology. Treatments. You can perform irrigation and debridement with component retention if you have a well-fixed prosthesis in the setting of an acute infection. In medically frail patients who cannot tolerate multiple procedures, you can perform a resection arthroplasty, though this is very debilitating. in subacute or chronic infections, you'll either be doing a single stage revision or more commonly a staged revision. And this is for chronic infections, a loose prosthesis, or virulent organisms. Thank you very much.